welcome everyone. I think we'll get started as people continue to enter. There's already lots of participants, and we're looking forward to this discussion today with you on the risk of novel synthetic opioids in Ontario. I have the privilege of co-hosting with Natalie Kaminsky from the Ontario Network of People Who Use Drugs. I'll turn it over to Natalie in a minute. We'll just do some acknowledgements to begin with. So first, acknowledging the land that we're on and hosting from today in Toronto is the land of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, the Chippewa, and the Wendat people is also covered by Treaty 13. And with acknowledging the land that we're on, we also want to acknowledge the commitments that we have within our current opioid-related project to be able to build capacity with other organizations and partners in working on overdose issues with Indigenous partners, learning first about the cultural competency and then cultural safety skills and meaningful relationships with communities. So we also are grateful to be doing that work with other organizations throughout this process. I also want to acknowledge people who use drugs and their strengths and resilience and innovation in this area and being leaders in solutions and reducing overdoses. And I think with that, I'll turn it over to Natalie for really centering the voice of people who have lived experience at this meeting and this conversation and the work of the Ontario Network of People Who Use Drugs.
So hello, everybody. The Ontario Network of People Who Use Drugs wants to welcome everybody to the presentation this afternoon and take the opportunity to introduce ourselves. Our network is a newly formed network founded by local drug user initiatives and networks across Ontario. Some of you may have seen our statement that went out on International Overdose Awareness Day, calling on federal party leaders to stop the war on people who use drugs and examine and implement a decriminalized model where access to the drugs we want and need would be made available through an evidence-informed best practice model outside of the illicit and toxic environment we are here to discuss today. The Ontario Network of People Who Use Drugs understands why the topic of novel non-opioid drugs may be interesting to investigate and discuss, but wants to remind the audience that today, while we are at this meeting, someone who uses drugs will die. And by the end of the day, 17 people in Canada will die. Our drugs are toxic and fatal. They have names we don't understand and compositions we are not used to, but this isn't new to our communities. Today they have benzodiazepines in them and analogs of strange fentanyls that change their strength and color. And if people like those of you here today don't join us in our cries for decriminalization, we will be back here again in 6 months describing their new names and toxicity with another approximate 3,100 Canadians dead of failed drug policy. The Ontario Network of People Who Use Drugs urges those of you here today with ability, access, and power to join us in the fight for our lives, and hope that beyond this presentation, each of you are examining your place and purpose in this fight and will reach out to our network and align with us in the future. Thank you very much.
Thanks so much, Natalie. So just as a really quick disclaimer, our presentation today includes the content of our external partner organizations and is being published after this webinar on the PHO website for the use of the partners and just not able to sort of assume liability for application or use of this information as part of our disclaimer. And next slide, please. So just an overview of the learning exchange flow of the session for today. Really the objectives are to understand the risks with novel synthetic opioids, identify best practices in overdose prevention and responses, and then describing opportunities for multi-stakeholder responses to overdose at the community level. Natalie and I have introduced ourselves, and then we will have our presentations from Karen McDonald at the Center on Drug Policy Evaluation, Reagan Murray at the Office of the Chief Coroner for Ontario. Also at this point, I'll introduce our panelists who will follow for the discussion after the two presentations. We have Ashley Smoke from Ontario Network of People Who Use Drugs, Mahari from Black Coalition for AIDS Prevention, or Black CAP, Nick Boyce from the Ontario Harm Reduction Network, and Jennifer Levy from Toronto Public Health and the Toronto Drug Strategy. So Natalie and I will facilitate the discussion with the panelists after the presentations, and then the questions from the participants in the webinar. And next slide, please. So just before we go to the content and our first speaker, Karen, we just have a couple of quick polls just so that you can introduce yourselves, where you're coming from in Ontario and what roles or organizations you come from, just so you get a sense of who's in the room for the conversation today. Okay, so it looks like many from public health, community agencies, some drug strategies, and some from other organizations as well. So just hoping others can see who's here and what organizations they're from. So at this point, I'll turn it over to Karen for our first presentation.
Perfect. Thank you, Pam. So thanks so much, Pam and Natalie. So as Pam mentioned, my name is Karen and I lead Toronto's drug checking service, which operates out of St. Michael's Hospital in Toronto. Next slide, please. So before I get started, I too would like to make several acknowledgements. So first, I'd like to acknowledge our community advisory board members, our partner organizations, and those that have lost their lives to the drug poisoning crisis due to policies of drug criminalization. I'd like to acknowledge the land on which we operate is the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I'd like to acknowledge that racialized communities and survivors of colonization are disproportionately impacted by unjust drug policies. And lastly, many of the samples we check are linked to both fatal and non-fatal overdose, as well as adverse health events that impact individuals, families, friends, loved ones, and entire communities. And I just wish to acknowledge the people and the pain behind the data and the numbers that I will present. Next slide. Next slide. Oh, there we go. Sorry. So just really quickly, I thought I would give a quick overview of what Toronto's drug checking service is, just in case folks on the phone aren't aware of it. So Toronto's drug checking service is a pilot project that is funded by Health Canada's Substance Use and Addictions program, as well as the St. Michael's Hospital Foundation. It formally launched in October of 2019 with implementation lasting approximately 3 years. So really what we do is we collect samples from people who use drugs, as well as harm reduction staff at 5 of Toronto's supervised consumption sites. And then 5 days per week, we have a bike courier who goes around to the sites, picks up the samples, and then brings them to either the lab at St. Michael's Hospital or the Center for Addiction and Mental Health, where they're analyzed to determine their composition. And then results are reported within a day or two from arriving at the lab back to the agency that collected that sample, where they're then shared with service users along with tailored harm reduction strategies. So beyond just informing, individual service users, we also combine results from the samples that we check to monitor the unregulated drug supply. And we share this information publicly, primarily through our website, but also relying on many of our partner organizations in hopes that this information can be used to advocate for services and safer alternatives for people who use drugs. So to date, we've checked over 4,000 samples, and this includes both substances as well as residue on used paraphernalia. Next slide. So I have been invited today to speak about a group of synthetic opioids, which are known as Nitazine opioids. So these are opioids that were synthesized in the 1950s to relieve pain, but were never clinically approved for market. And there really aren't any reports of these drugs between when they were synthesized in the 1950s until 2019, when they started to present in the unregulated drug supply. So between April of 2019 and March of 2020, there are reports or first reports of these Nitazine opioids presenting in either substances that had been seized by law enforcement or in toxicology reports throughout Europe and then in the US. As far as I know, the first time these Nitazine opioids were identified in Canada was in August of 2019 by Alberta's toxicology lab. And then in January, Health Canada's Drug Analysis Service first identified them, which Reagan will get into in the presentation that follows. And then our service here in Toronto first identified these drugs in February of this year. So based on my research, there are at least 14 Nitazine analogs, and these drugs are considered to be as strong or up to 20 times stronger than fentanyl. Next slide. So by the end of August, our service had identified Nitazine opioids in 73 samples that we had checked. So these 73 samples were primarily expected to be fentanyl, but also expected to be heroin, carfentanil, or down. So when we collect a sample from a service user, we ask them, what they got or bought that drug as. And so primarily these were, drugs that were thought to be fentanyl. We've identified 6 types of Nitazine opioids overall, so mostly metnitazine, which is considered to be similarly potent to fentanyl, followed by isotonizing, which is considered to be 5 times stronger than fentanyl. And then we've also seen etnitazine and etonitazepine, which are considered to be at least 10 times stronger than fentanyl. And then just recently, we identified protonitazine, which is considered to be 2 times stronger than fentanyl. Next slide. So in terms of trends, I'll focus on Nitazine opioids presenting in the samples that were submitted as fentanyl or expected as fentanyl. So from this graph, you can see that over the first 15 months or 5 quarters of implementation of our service, we didn't identify any of these Nitazine opioids in the fentanyl samples checked. And then in Q1 of this year, so between January and March, we found Nitazine opioids in 1% of the fentanyl samples checked. And then in Q2, so between April and June, we found these Nitazine opioids in 5% of the expected fentanyl samples checked. And then so far in Q3, so July and August, we found Nitazine opioids in 18% of the fentanyl samples that we've checked. So really what we're observing is, the introduction of these Nitazine opioids in samples that we've checked, and then an increase in the types of Nitazine opioids that are presenting, and then an upward trend and a significant upward trend in the number of samples these drugs are presenting in. Next slide. So this graph shows the drugs that Nitazine opioids are most commonly found alongside in the samples that we've checked. So Nitazine opioids were found alongside caffeine in 77% of the samples, alongside a benzodiazepine-related drug like atizolam or flualprazolam in 66% of the samples, and alongside fentanyl in 64% of the samples. And then 23% of the samples included a Nitazine opioid and phenacetin, which is a fever-reducing, pain-relieving pharmaceutical that was pulled from the market in Canada in the 1970s for its association with kidney and bladder cancers. And then lastly, 7% of the samples contained a Nitazine opioid and xylazine, which is a tranquilizer typically used by veterinarians on horses and deer for sedation and muscle relaxation and pain relief. So what's noteworthy about Nitazine opioids presenting alongside fentanyl is that they're both highly potent, so the risk of overdose may be increased. and also using opioids in combination or using opioids in combination with other central nervous system or respiratory depressants like benzodiazepine-related drugs or xylazine actually increases the risk of dangerous suppression of the vitals. So what this means is there's an increased risk of, slowing down of the breathing, slowing down of blood pressure, slowing down of heart rate when these drugs are being used in combination, and that is exactly what we're seeing. Next slide. So just a few other things that I'd like to note about the samples that contained nitazene opioids that we checked. So in 22% of the 73 samples that contained a nitazene opioid, the only opioid that was found was a nitazene opioid. So this means that like a fairly significant proportion of the samples that contained a nitazene opioid, like replaced the intended opioid. So, people thought they bought or got fentanyl or heroin. In fact, in a fairly significant proportion of those samples, there was no fentanyl or heroin present, and instead there was a nitazene opioid. 8% of the 73 samples contained more than one nitazene opioid. So this means that, these drugs are presenting in combination, which, as I mentioned earlier, could increase the potency of the drugs overall, could increase the chance of overdose, could increase the risk of dangerous suppression of vitals. And then 15% of the 73 samples were reported by service users or by harm reduction staff as being associated with an overdose. So of course, because the combinations in these samples that we're checking are so complex, we can't say, oh, the overdose was directly caused by the nitazene opioid, but this is a significant number of samples that contain those opioids that are associated with overdose. So it's certainly something we're keeping an eye on. And then just lastly, in terms of sample characteristics, this is information that we collect during sample collection. The colors of the samples that contained a nitazene opioid were primarily brown, but then there was a large variety of other colors, including, green, purple, blue, pink, yellow, red, and so on. Next slide. So that is all for me. Thank you very much for listening, and I'm happy to answer any questions during the Q&A, or you can email our service at any time at the address that's included on the screen here. And I would just encourage you to check out our website. We do update data from samples checked every other week in an effort to just disseminate this information as widely as possible and inform those who aren't able to directly access our service. So thank you again, and I think I am handing it over to Reagan now.
Great, thanks very much again for the opportunity to present. So my name is Reagan Murray, and I'm a public health officer epidemiologist placed at the Office of the Chief Coroner. But the funding is through the Public Health Agency of Canada, Canadian Public Health Service. And so today I'm going to actually present the majority of the time related to the Health Canada Drug Analysis Service data. But this is not Office of the Chief Coroner specific data, but something we have access to, and I think provides an important window into the drug supply outside of Toronto. And then I'll provide us an update from the Office of the Chief Coroner, again, related to these new nitazene substances. Oh, next slide. So just a little bit of background about the Health Canada Drug Analysis Service. The link is there if you're interested in learning more about it. It operates laboratories across Canada that analyzes suspected illegal drugs seized by Canadian law enforcement agencies predominantly, and is also a small proportion of samples that may be submitted from a death investigation scene is also included in some of these samples. And so the DAS shares raw anonymous data on samples analyzed and quantified from each province and territory on a monthly basis, and that is the foundation for some of the information I'm going to be sharing here today. So in 2020, just for context, about over 33,000 samples were tested in Ontario. So a note from the data source that I do want to refer to in context and interpretation caution on some of the interpretation. The samples are analyzed by DAS, but may not represent drug seizures, across Canada or what's circulating in the drug market. And we need to be careful with drawing trends or making comparisons. But with that being said, I do think it is an important window that we can do some learning from. So I'll continue on with a few data notes and limitations that will help interpret the data. So note that the samples that will be reported on there could be multiple samples may have been detected in a single sample. So for ones, so this co-detection of substances in a single sample is important context. And then we cannot discern if samples are pre-street seizures versus seizures already in circulation. So multiple samples can be drawn from the same seizure, and we cannot determine the size of the seizure. So again, that's an important context that as well. And samples can include tablets, powder, residue, syringes, etc. So routine reporting began in August 2018, and samples are included in that routine reporting once the result is returned to the client, which is the police service or detachment. And it can be weeks to months after the seizure date, which is an average about 75 days before it's reported back to the client. So then therefore it takes about 3 months for it to be reported routine into the monthly reports. So in February 2020, they began reporting a new date, which was reflected the date that the sample was received at Health Canada DAS. So that is a little bit closer to the time that the sample might have been seized, although it is possible that the police detachments had held the sample before being submitted. So again, becomes a better date marker, but not perfect. And as well, customer city was also reported, and to help again understand a bit of that distribution of samples. But again, to note that this reflects where the police department or detachment is located, not the location of the seizure. Next slide. So on this slide, I've listed off the isotonizing. First, we can just take a look at that. And from January 2020 to May 2021, 46 samples detected isotonitazine. The first was detected in January 2020. And there's been at least 20 regions, so that's police detachments, with a positive sample reported. And there's the proportion of samples where fentanyl was co-detected was about 17%, so a little bit lower, as you'll see, than some of the other nitazines. And as well, benzodiazepines was also detected in a smaller proportion. So with respect to Nitazine, we've seen over about 188 samples reported. The first report was sample was submitted in August 2020, and again, 40 different regions across the province has had at least one sample submitted. And similar, I can't say this one, Isotonizing, almost exclusively was fentanyl, was co-detected with fentanyl. Nitazine was also detected first in August 2020 in about 24, and 24 since then, 24 communities have reported at least one sample with this detection. And then more recently, with the first sample submitted in March 2020, we have seen at least 6 samples where proton nitazine was detected. Next slide. So again, just to caution with thinking about trends, but we can see here that there are some different patterns in terms of number of samples. In green, the Isotonizing had a few more samples submitted in August to October last year, and then again, it's like sort of emerging in March, April, with some more with an increased number of samples. Similarly with Nitazine, although first detected in summer, fall 2020, we've seen much an increasing number of samples with this detection in 2021, this spring. Next slide. And although this is a very lot of information on this slide, I wanted to just demonstrate the breadth of the detection of some of these substances in different regions across the province. So this reflects detection of one sample, at least one sample submitted with these substances tested positive from these regions across the province. Next slide. And also when considering place, it does appear this slide indicates detection of nitazine as a group in HCDAS samples submitted by province in the last August 2021 report. So again, this is just a 1-month snapshot of what was reported in that most recent report. In Ontario, there were 73 samples with nitazine detected, and 5 or fewer in Alberta, Manitoba, and Quebec. So there's potentially a different pattern occurring in Ontario. The next slide. So moving on to an update from the Office of the Chief Coroner, I'll just focus a little bit on testing capacity and what we know to date about involvement in death investigations. So I want to note that many death investigations for 2021 are ongoing. So finalized investigations may identify additional deaths where there was involvement of these substances, and we will continue to monitor. So the Center for Forensic Sciences conducts the toxicology testing for the death investigation system, and for isotonizing, Nitazine was the first Nitazine that there was developed testing capacity for, and so there's qualitative detection. That means we can detect traces of the, but we cannot at this moment quantify the concentration. And there's been, again, to date, 1 death at the end of July 2020 in Toronto where this was detected in the postmortem toxicology, but the investigation is ongoing for the final conclusion on the cause of death. Nitazine, again, we can do qualitative detection at the Center for Forensic Sciences, and this was attributed to 1 death in September 2020 outside of Toronto. There's also some other nitazines, I won't pronounce them, but that we have qualitative detection and several others that are on the radar and in development. So I'll just kind of close, next slide please, with just highlighting some of the most current trends with respect to opioid-related mortality and suspect drug-related deaths in Ontario to provide some context. So suspect drug-related deaths continue to be elevated through the summer months and into September, where we've had over 300 or more deaths reported over the summer months. And to date, from January to May 2021, about 1,200 opioid-related deaths have occurred. And sadly, this is on pace to be similar or greater in number of deaths as 2020. 88% have involved fentanyl. At least 50 deaths involved carfentanil, and we're continuing to see carfentanil detected in deaths in June and July, and 65% of deaths of benzodiazepine was detected in postmortem toxicology, which is increasing since 2020. So I'll leave it there, and really thank everyone for the opportunity to participate and share some information. Looking forward to how this might be useful and hearing the discussion panel.
Great. Thanks so much, Karen and Regan, for those informative presentations. I apologize for putting you on the spot for pronouncing such challenging chemical names, but I think your work to pull together so much information from the Ontario context for people attending today who are in practice in this area is really important work. So thank you for sharing that and it's sort of rapid recent information, which was our intent in coming together quickly around this. So we will move over to our panel discussion. We have the oh, sorry, I have a couple of slides on our risk assessment that we conducted at Public Health Ontario just before we go over to that. So Just on the next slide. So this document our rapid review of the evidence and risk assessment, including some of the information from Ontario presented today, will be available after this session as a PDF to the participants, and then posted shortly after on our website for further sharing. So just to put all this information together with some of the literature in this area, we really wanted to focus on the novel synthetic opioids emerging in the Canadian context, and just thinking about the importance of considering the potential impact in Ontario on morbidity and mortality, and how the information fits together to assess risk. So we were looking at the literature from 2011 onward, and looking at either the characteristics of these compounds, exposure to them, or outcomes, and looking at information where there was an actual study design rather than a commentary or a narrative review. And I want to also credit Imran Khan, who's been with us as a resident physician in public health, for working on this as well. And I believe he's attending today. So thank you, Imran, for contributing to this. Next slide. So really the bottom line was we found 6 articles that met our criteria, and about over 1,000 results that we screened. Some were around exposure to these chemicals, and some were around the severity of outcomes. So around exposure, there was an article on searching the darknet markets on the internet, and searching for the novel non-fentanyl synthetic opioids between September and August of 2020. There were 17 that were identified in the benzimidazole or the Nitazine class, and 14, or sorry, of the novel synthetic opioids that are non-fentanyl, there were 17. 14 of those were listed for the first time on these markets, and then 5 were the Nitazine class, and Nitazine was the most common. On Reddit, there was another scan of social media around these compounds. And there were 7 of 8 of the novel psychoactive substances, including isoniazine, that appeared prior to their implication in poisonings in the community. So they thought in this study that there was an implication for looking at social media for early warning. It's a predictor of trends of exposure in the community to novel synthetic substances. Also, there was a review of deaths in the United States, some that were caused by isotonizing, and then also comparing with 981 other deaths with synthetic opioids. So you can see in this period of time from January to July, there were more deaths from other synthetic opioids, which I think fits with what we've heard in our context as well, as this is emerging. And isotonizing deaths involved a greater number of other substances and included fluoprazolam, the benzodiazepine that was mentioned earlier in the Toronto drug testing information. For severity, there was a study that actually synthesized 10 different nitazines and 4 metabolites, and analyzed them, looking at their potencies, with some greater than fentanyl, as we've heard in this conversation already. Some of the metabolites are stronger than the precursors. When it breaks down, it's an active metabolite that's even stronger, which signals the risk involved. And some of them are very simple, cost efficient to manufacture, as well as having non-regulated precursors as a risk for them to emerge. In 3 deaths in Switzerland, were in the literature as the earliest in Europe, and one of these deaths was in March of 2019. 2 involve benzodiazepines and 1 involved ethanol, and there's implications for screening and testing items at the site because they felt like these compounds might have been missed in the death investigations because of their low concentrations, high potency, if the material from the site had not been tested. And a last review of other deaths between November 2020 and February 2021 in the United States context involving Nitazine. They were all accidental. The Nitazine contributed to death. 30% had the Nitazine as the only opioid. So this is maybe a parallel with that information from drug checking in Toronto, and there's implications for forensic testing to be able to comprehensively monitor these substances in death cases. So just the next slide, please, Trudy. In our risk assessment framework here, we looked at what are some of the issues underlying risk, as well as the level of risk and the degree of uncertainty. And this isn't an exact science, but based on what we know so far, we've characterized some of the risk around increased exposure, overdose severity, the potential for lowered effectiveness of our interventions that we have right now, and the impacts on testing and surveillance in the system overall. So in discussion with those involved and part of the group today, thinking that the risk level is moderate for an increasing prevalence in the drug supply of these compounds, but still most people are also exposed to other synthetic opioids and benzodiazepines. For overdose severity, they contribute to moderate to high risk. And there's a spectrum of the potency exceeding that of fentanyl. And it's often found with other sedating drugs, such as the benzodiazepines. For interventions, the risk level is moderate. There's naloxone would work at the same receptor for opioids, but you may need higher doses with higher potency. And there's prolonged sedation with other drugs being involved. And the impacts on testing and surveillance, there's a need for testing to be available for harm reduction, healthcare, and forensic purposes that's not yet widely implemented. And some of the information around exposure, severity, and the effectiveness of interventions is still fairly uncertain, just given that this information is still emerging. Next slide, please. So key messages in the risk assessment that will be circulated as a PDF after this discussion. So the novel synthetic opioids have emerging presence in the unregulated drug supply, including samples from communities and deaths in Ontario. There's uncertainty due to the small body of relevant information, testing limitations, and overall toxicity of the unregulated drug supply. The severity of risk of severe overdoses is moderate to high, with potential to need higher doses of naloxone. The available information supports continuing with current approaches to overdose prevention and response, and new and innovative public health approaches and community-led responses are needed to address the toxic drug supply and improve safety for people who use drugs. So I'll leave it there, and really interested to get into our panel discussion. And just the next slide, Trudy, thank you, and just the references that we included. And I think for the panel discussion, we'll just go to the gallery view, and I'll turn it over to Natalie to start with our first prepared questions for our panel. I'll invite all the panelists to turn on their cameras and let you go ahead, Natalie.
This question's for Ashley. What are community members experiencing in the context of novel synthetic opioids? So the NSOs and non-fentanyl, and examples could be information, managing risks, reactions to drugs, withdrawal symptoms. You're on mute, Ashley.
Sorry. Not every region has like community drug checking services. So a lot of communities in Ontario, a lot of folks don't really know that these drugs are in their drugs. Like they're thinking that they're taking fentanyl, and that can be really dangerous when we're talking about like the potency of some of these drugs, like being much higher than fentanyl. Also, the data doesn't translate to the community very quickly. We're not getting the information out to the people who are responding to overdoses in the community as quickly. So oftentimes people are using lots of Narcan because people aren't waking up, but they're breathing, but they're not aware of like these overdose prevention tools and stuff, because the data is so far behind. Like what we get on the street is like happened ages ago. Like, so it's kind of, we're kind of like reacting instead of proactive. Also, the protocols at some of the supervised consumption sites, they're pretty much the same. Like they let people sleep off they let people sleep it off there, but then at the end of their shift, some of them have to call an ambulance, and that can be traumatic for the community members who trust these services that they're going to. And then other communities don't even have safe consumption sites. So some people are using alone, and that's an increased risk. And communities with less access to services have less access to information. And that's also a risk when it comes to overdoses. And yeah, the biggest reaction when it comes to the drugs though is like people are blacking out and not remembering things. And that's really dangerous when you think about like your life. Like you have a risk of like losing your friends, your housing. You could commit crimes or be victim of crimes, like, and you don't even remember it. And it's all because of a toxic drug supply. And that, like, in my opinion, like taking a substance it having the ability to alter your life, like that's very scary. In terms of strength and tolerance, people, like you have to use naloxone to wake some of these people up, and then you can put them into rapid withdrawal, and that can be very dangerous when you're not putting someone onto safe supply afterwards. And that doesn't always happen in every region in Ontario. And then when your tolerance is high and the potency of the drugs vary in such a way where different batches are way different potencies, the effect can lead to an increased risk of overdose, because one batch could be weaker and then the next batch could be like so strong, and then you can overdose. And then when it comes to withdrawal management, like methadone and OAT doesn't touch people's fentanyl withdrawal needs. So when you're talking about these substances that are much stronger than fentanyl, it's kind of like not fair for people who use drugs to have to go through these withdrawal symptoms just because doctors are unwilling to meet their withdrawal needs. And like you have these like kicking leg syndromes, you vomit, you have cold sweats, you have a fever, like it's crazy. And doctors should be adjusting their protocols and care to meet the needs of the patients and where they're at in their withdrawal needs. Even though their dose might get high, like it is what it is. Like it's better than being sick all the time. There's also like a depression, or like when people withdraw from these specific opioids, there's like a really deep depression and like benzo kind of withdrawal that happens afterwards. And a lot of times it's left untreated because people are focused on like opioid treatment and not the benzo withdrawal. So that's another issue. And even safe supply, like that is a better option, but it still only addresses the needs, like the withdrawal needs, and not the actual purpose of the program, which is to give people a regulated supply of the drugs that they want to use. Like they're just actually just making their withdrawal manageable, and that's not the point of safe supply. So those are the things that I've really noticed in the community with these drugs. But the biggest impact is the death toll. Like I lose a friend every week and I'm just one person. So I can just imagine what the community in terms of like the impact of death and decimation.
I would agree with a lot of what Ashley said, and would just add that as somebody who works in harm reduction in the community, my job has shifted quite a lot, where many years ago I could provide people with tips and tricks, and now I'm simply supporting a lot of grief and trauma, collecting names of the dead, and advocating to physicians for people's medical needs, especially seeing a lot of folks having seizures and trying to get family doctors to understand where the seizures come from, which is part of the withdrawals. So thank you, Ashley, for your input. Pam has the next question. Thank you.
Thanks, Ashley and Natalie. The next question we prepared is for Mahari, and from the perspective of the services that you're involved with, how has the current drug supply, including the novel synthetic opioids, affected the communities you serve and your approach to harm reduction in the community?
Thank you very much, Pam. At the Black Coalition for AIDS Prevention, where we work with the ACB community, African, Black and Caribbean communities, I have to be, true to the work that we started as Black Cap. We started the work from a HIV perspective. And so that mandate has expanded over the years, and now we are also doing a lot of work in harm reduction. And so when we deal with issues, I like to say there are many epidemics happening at the same time, because, in our community, particularly, HIV is still a problem. We are still dealing with that in a different way. While other people are talking about the 1990 cascade, we haven't hit those numbers. We are very far away from those numbers. But we are also, dealing with anti-Black racism, and, that compounds a lot of the issues we are working with. Recently, and this is, we are, like the last speaker, Ashley, we are burying people every week, and we are talking about people we know, our colleagues, our friends, family, and that's just us as an organization. There's a lot of death. We are sitting with a lot of death in the community. We are sitting with a lot of anger in the community. We are sitting with a lot of questions in the community, because every time we ask specific data about the ACB community, the answer is more or less the same. We do not have anyone invested enough to look at these data so that we can translate it to our communities. When we go to spaces where people are discussing data, they are using academic language, sometimes very restrictive, and we don't even know how to translate it. For instance, I would be interested to know what's happening with, contraindications, people who are on antiretroviral therapy. What are they? What are the challenges? So whenever there is a death in the community, there are so many questions. We don't know how to, sort of synthesize this information. And it is not a lack of capacity, it's more a lack of investment in, being more deliberate about what is happening in the community. So a lot of community centers in the last few months have been closed because of COVID-19. So our communities are not accessing spaces that they would access initially or traditionally access easily. Now there are so many restrictions. And so what does that mean in terms of, our strategy to do harm reduction work? So we are, and I have to say this, our team, harm reduction team, we have a big harm reduction team with a lot of peers. And it's my first year at Black Up. This month is my, first year anniversary. And the impact on the staff, the impact on the peers is so much, it's so hard. At one point, we couldn't even do outreach because we were at different stages of recovery from COVID-19. And, that impacted what is happening out there in the community. We are finding a lot of community members dying alone in their homes and staying there for so many days before they are discovered. So, the easiest thing considering COVID-19 protocols is maybe to call people. But what about people who are facing barriers? They don't have access to hardware. They don't have access to software. They don't have access to data. They are either in shelters or are precariously housed. And so it's very difficult to reach them. Yes, we are doing very many, every week we are doing outreach sessions, but most of these are virtual. And when we ask peers and staff, to do outreach and to do safe drop-offs, again, what does that mean in terms of safe drop-off? Because you have to think about how to protect the staff, team, and peers, but also the urgency to go out there and reach our community with information. We would have a conversation, have a discussion about what's happening, have that in-person touch. Now you have to speak to someone when they are at a distance. You have to have full PPE. There's a lot of barriers related to that. So the strategy is to, of course, have a blend of both of all these methods, be sure that we are able to deal with food insecurities. So we are doing, every 2 weeks, we are doing food supplies to community. So working with volunteers and our peer leaders. We are also making sure that we use online spaces, but also make phone calls and visits and doing health checking in with community members and trying to make sure that we support people not to use alone, because that has become a big problem. But we are facing challenges, like most of you, I am sure, who work in community of resources. This work is labor intensive. This work requires people to be out there for many shifts. But most resources we have, especially for peers, because they do a lot of work, are so limited. They're poorly paid, minimum wage, no benefits. So what does that mean? And every time somebody tells us, apply, all these resources are out there, most of the resources available are competitive and they are not community friendly. So it's Hunger Games out there. To get 15,000 for one peer, and that's really the lowest amount, you have to do documents and documents and documents, application documents for you to get that. So we have very limited resources. We are not looking at it as a human rights-based approach, in the sense that if we have to be present in community, we also have to compensate people fairly. So it's a gamble between that, yes, passion is there, the passion to work is there, but how long can you do this without resources? So we've also started as a strategy because we've realized that, mental health issues are going to be there for a very long time. Even the grief we are facing, I haven't processed. In the last year I've been here, every single month there is a death, usually because I worked with, a BRPO before. I worked with Nick next to my office before, and we were dealing with grief. I had an opportunity to sit with my grief and process. We haven't done that. We don't even have time to do that because every time a death happens, another one happens, and you have to move on and work. So we are sitting with a lot of grief. We haven't done any impact debriefing. A lot of our community members haven't seen even their doctors or their family doctors for a very long time. So all these issues we have started a trauma-informed care program that will run for about 18 months because we recognize that people have to be supported for a long time. And our therapist is doing mixed methods, doing individual sessions and group sessions, and also is able to see people in person by appointment and also to see people virtually. So all these are things that we are trying to do in the context of limited resources to try and support our community. Sometimes we don't even know what is out there, so what we are doing is just broadly being there for community and trying to support them as much as we can, but it is quite difficult. Thank you very much.
Thanks so much, Mahari. I think that's so powerful and vivid to hear about all of the intersecting issues for your clients, and then also the challenges in being able to meet people's needs with your services, and how you're innovating and being able to attempt to meet that need. So thanks so much, Mahari. Back to you, Natalie.
So, Nick, given different contexts across the province, how are harm reduction programs and services in Ontario adapting, including the approach to overdose prevention and response?
Thanks, Natalie. And I'll just say that Ashley and Mahari have already talked about a lot of what I was going to say, so I'll repeat some of their points and then add some pieces in. In terms of basic overdose response, I don't think anything has really changed with the introduction of novel opioids. It's the same basic messaging. It's check your supply and source your drugs as best you can. Access safe supply programs, if at all possible, but those are so minimal in terms of access around the province. Use in the presence of others as best you can. If you're lucky and can access a safe consumption site, do that. But we know 75% of the overdose deaths in Ontario happen in people's own homes. So try and use with others. Oxygen and naloxone when people go down, rescue breathing, giving people oxygen support and using naloxone, and 911 and medical support. These novel opioids really haven't changed anything from that perspective. In other ways, everything has been changed in the last few years when it comes to harm reduction. There's nothing new about new substances coming up in the supply. It's just that, as Ashley said, we don't know about them until well after the fact, when drug checking or toxicology reports show up. I think about we see reactions happening to people, and we just don't know what's in there, and until we get those drugs tested. A couple of things specifically around some of the newer opioids or the benzodiazepines, and I think Ashley touched on this, though, is there may be a need to retrain people on the use of naloxone, because it used to be people would give naloxone and people would start breathing and wake up. And this is more to do with the benzodiazepines and less to do with the opioids and the new opioids, but people just don't wake up anymore. So we need to really get people to focus on whether people are breathing or not. In the safe consumption sites, that's put a real strain because on supporting people, because you basically have people sleeping all over the place and you're having to look after them until they wake up. So that impacts your ability to then engage with other folks. I do have, I've been very concerned for the last few years in terms of the impact of some of these new drugs or on overdose, but then the impact of overdose on brain injury, because people are going without oxygen getting to their brains. We're going to have a wave of brain injury happening across the country, and how we're going to support people around that. Another thing we don't know about a lot of these new opioids, but we do know this from fentanyl, is what we talk about, the duration of action. So how long do those drugs last in the body? And when people used to use heroin, they could inject 1 to 3 times a day and they'd be okay and they'd get them through their day. These days, a lot of these newer opioids have very short durations of action, which means they wear off very quickly. And it's not uncommon to see someone at an injection site have to inject 12 to 15 times a day. So I'm very concerned about the impacts on HIV, Hep C, endocarditis, the bacterial and viral infection risks that we're going to be seeing. This also means that people have to spend a lot more money on their drugs, because the price of the drugs hasn't changed, but they're spending a lot more on their drugs. And that means people are engaging in more survival sex work, break and enters. I mean, let's get real. People aren't criminals, but they're being forced into so-called criminal behavior just to survive. I think I've never seen the level of desperation and despair in people that I've seen now. I think the most dangerous thing is that people have lost hope. And, I've seen people digging through biohazard bins just to try and score their last bit of drugs that are left in someone, left in there. And they don't care about HIV or Hep C risk for doing that anymore. They've given up. That is very dangerous when we've got to that point. As Mohari and Ashley said, the impact of the trauma is just, people are just not getting the supports. People are having to pick and choose what funerals to go to. There's more people dying than at the height of the AIDS epidemic. And there's no time, as Mohari said, to even process the deaths. It's just relentless. So, in terms of trying to think about how we move out of this, it's sort of, it's whack-a-mole. We keep restricting one drug and then another pops up, and then we look at another one. I think until we see a fundamental shift in our approach, and talking about decriminalization is one thing, because that reduces the stigma. It allows us to shift failed police resources and prohibition resources. I mean, how much money are we spending on failed drug interdiction, trying to stop the supply of drugs, policing it, prisons and courts, and it hasn't stopped any of the drugs, and actually it's created a more toxic and dangerous supply. So decriminalization, where we don't have to enforce the stuff, shifts the resources and it moves it to a truly health-based approach, not a criminal moral issue. But it actually has to move beyond decriminalization, because that doesn't address the toxic supply, and we need a legal and regulated supply of drugs. And we need to look at those models of legalization. Alcohol is not a great one, but let's get some sort of, it's my personal belief that if you're working with people who use drugs and you truly want to improve their lives, you have to have discussions on decrim and legalization. Otherwise, nothing's going to change. And as I think Ashley said, or someone said it, that 6 months from now, new drugs are going to be coming up, and we'll do an evidence review of those drugs and have another webinar to talk about the impact of those drugs. And nothing's going to change. Happy to take some questions later on, or come back to some of those points.
Thank you so much, Nick, for some of that information. Obviously, in our introduction, the Ontario Network of People Who Use Drugs agrees that we need to start looking beyond this and moving into how are we going to get past the illicit supply. Otherwise, we're always going to be behind the game, talking about what's in the supply, while also counting how many people have died. Thank you.
Thanks, Nick and Natalie. Our last prepared question is for Jennifer. How are drug strategies and other groups responding to the unpredictable drug supply, including the novel synthetic opioids, through their policy and advocacy work? I think this dovetails from what Nick was just sharing as well. So just for your remarks on that, Jennifer, please.
Thank you, and thanks to the panelists, as well as to the for the panelists for sharing their perspectives and experiences on this, as well as to the presenters. So I want to start by acknowledging that, I'm speaking from the Toronto Drug Strategy, where we're in a privileged position in Toronto to have access to drug checking services for the city. So as we've discussed in Toronto as well, we're seeing an unprecedented increase in deaths due to the drug poisoning crisis. So the Toronto Drug Strategy does monitor the number of fatal and non-fatal opioid overdoses related to calls to paramedic services. And when we do see a period with a significant increase in calls or an increase in the number of overdoses at supervised consumption services, we are able to connect with drug checking services to share information. And that's incredibly helpful for us because it can help us to understand and contextualize what is going on. And based on this surveillance and what we're seeing from drug checking services, we issued reports, drug alerts to harm reduction organizations and the public to let them know that there has been a spike in overdoses and that there are new and unexpected substances in the unregulated supply. So we really do try to get that information out there and reiterate the harm reduction messages. We have advocated for, related to safer supply, federal funding for safer supply programs to address the unpredictable drug supply. Currently, safer supply programs in Toronto, including injectable opioid agonist therapy programs that's newly available at the works, are only funded until about March 2023. So we have most recently urged the Federal Minister of Health through the Board of Health to provide additional funding for longer term safer supply programs, including injectable medications and other safer supply options, including for stimulants. And at a provincial level, we've asked the Provincial Ministry of Health for support and funding to implement a spectrum of safer supply options. And part of this includes listing high-dose injectable formulations of hydromorphone on the Ontario Drug Benefits Formulary, and that these formulations aren't listed on the Ontario Drug Benefit Formulary is really one of the barriers to safer supply programs, as well as programmatic funding. So the Toronto Drug Strategy joins together with other drug strategies across the province as part of the Municipal Drug Strategy Coordinating Network of Ontario. And through this collaboration, we've collectively also advocated for increased funding for safer supply programs, both at the provincial and federal level. And then also what we've been talking about in relation to decriminalization. Since 2018, Toronto Public Health and the Toronto Board of Health has been calling on the federal government to decriminalize the possession of all drugs for personal use and scale up prevention, harm reduction, and treatment services. And we've called on the Federal Minister of Health to use the authority under the Controlled Drugs and Substances Act to permit the simple possession of all drugs for personal use. So most recently in June 2021, the Board of Health asked Toronto Public Health to convene a working group to develop a model for decriminalization for the City of Toronto. And this work is underway now, and we will be submitting a request to Health Canada for an exemption under the Controlled Drugs and Substances Act. But I'm also happy to take questions during our discussion period.
Thanks so much, Jennifer. I see 2 questions in the chat so far and invite any of the audience members to add questions. I'll read the first one from Benoit, and then I think Natalie, if you can read the next one from Lisa. So the first one is, do we know the origin of this drug in the Canada's supply? Sorry, I'll say that again. Do we know the origin of this drug in Canada's supply? So I wonder, maybe Reagan, would you be able to start with that one and then invite any of the panelists or others to contribute?
Thanks for calling on me, Pam. Unfortunately, I don't have any insight to offer to this. Sorry, I don't have any context on that to provide.
I might say, like, from the one of the articles in our evidence review, and this was looking at the web listings of the availability of these drugs to order. There was about half of them in that review that were available from China, and the rest were available from a variety of other places. So I guess that's what I have seen in the literature. But I think for, yeah, Reagan, I haven't seen other information either when they're, you know, from Canadian drug seizures or anything like that, if there's any information on where they're coming from. Do others have information?
Yeah, Pam, I think a couple of things. We know that historically, a lot of the fentanyl and analogs were coming from labs overseas, primarily India and China. More recently, with some of the benzos, we know that's also the case. And we have seen, I saw some data recently that looked at border seizures of benzos, and they were very pure. But by the time they get to the toxicology or drug checking services, they're a mixture of things. And I think it's really important to know too that people are not using these drugs. It's not you're just injecting one drug. When you actually analyze those samples, there are multiple compounds, multiple chemicals within those drugs. And there's often multiple fentanyl analogs in a sample, or there's caffeine bulking agents in there. So it's just people have no idea what they're using. We don't even know what people are injecting anymore. It's just a big toxic mess. And at some level, it doesn't matter where they're coming from, because it's just a big mess of stuff that people are using.
Yeah, I think that in preparing for this webinar, I spent quite a bit of time online, and it's incredible how many different forms of fentanyl and the pricing. And I'm a substance user, and I've been part of the community for a very long time. And going online and trying to purchase something, when you see a price of $15 for fentanyl, but it's simply labeled as white powder fentanyl. And then, there's a yellow fentanyl that's $20. I think that people are experimenting online because of how costly it is to be able to keep yourself from withdrawal symptoms. There aren't resources available. Even, what Ashley said about safe supply, people are simply and rarely even matching their withdrawal needs. And so it becomes a game of price and cost and availability. Dealers don't know what they're getting anymore, and they're just trying to keep up with the demands. I know a lot of dealers that are just exhausted from trying to be able to keep up with what people are needing, and people are purchasing $10, $15 at a time, because it does take all day just to manage to get to a point of feeling well. So I think people are experimenting quite a bit with the internet, more so than they were before. And as we see more and more seizures of, larger quantities of heroin locally, in the region of Peel, we had a massive bust of heroin that occurred in our region a few months back. And it's a shame that happened, because that being out on the street probably would have kept a lot of my service users and friends alive. So I will move on to the next question, unless somebody else wanted to speak to that question, but I don't see any of our speakers nodding that they want to turn there. So the next question is, at Toronto SCSs, do service users have access to drug testing results on the spot to inform their use? And I think that question was for Karen or Jennifer.
Hey, yeah, I'm happy to answer this one. So Our drug checking service is piloting what is known as off-site drug checking. So samples are being collected at the harm reduction agencies, and then they're being analyzed off-site at a nearby lab. So with our current model, results are not available on the spot. And we totally appreciate that this model does not work for many people, especially those who are at highest risk of overdose and cannot wait days for their results. So there are on-site drug checking models that are also being piloted, specifically in BC, and I know one of our colleagues from BC is actually on this line. However, the issue is many of the technologies that are currently available for point of care checking have trouble analyzing complex mixtures, have trouble identifying like new or novel drugs, have trouble identifying drugs that are in trace amounts. And what we know from checking opioids is that is exactly what opioid samples are. So at this point, there's no, perfect solution to checking opioids in particular. All of the models kind of have trade-offs in terms of turnaround times and costs and like sophistication. And really like the field of drug checking for opioid overdose prevention is still quite new, but the technologies are evolving, and we hope that projects like ours will be able to kind of help shed light on what is needed and ultimately make drug checking more accessible.
Great. Thanks, Karen. I don't know if anyone else wants to comment on that question, or we can move to the next one.
I think the other issue with the current drug checking technologies, even the point of care, is they don't give you any quantity analysis. So you still don't know how much you actually got. And that's another big component to this, how much is actually in the sample. It's not just what the contents are, but how much you're doing too. It's not like liquor and beer where it's quality and potency assured.
Yeah, so our service actually just launched quantitative results. So we are able to quantify fentanyl and caffeine and carfentanil, atizolame, and cocaine. So if somebody submits a substance sample and their substance sample has one of those 5 drugs, we're able to tell them exactly or quite precisely how much of the sample they submitted is one of those drugs. The issue is the quantitative method, it's quite sophisticated, and it's not like we can change it on a dime. And the issue is the drug supply changes on a dime, right? So right now we're quantifying fentanyl, but if we kind of, and I'm not saying this is going to happen, but if by chance fentanyl kind of starts phasing out a little bit and these Nitazine opioids start phasing in, we're in this pickle where we built our method to quantify one thing and now it's something else, right? So again, it's just hard to keep on top of things. But Nick, you're totally right. They're
not getting the results immediately and then can say, oh, now I know what to do.
Right.
After the fact, or
Yeah.
Oh, can I answer? Oh, sorry.
Go ahead, Nick.
No, it's okay.
The next question was from Catherine. Will the NSOs be added to the PHO interactive opioid tool under drug type in the future? So Reagan, I will ask you just to collaborate with me on this answer, because my understanding is that it would be based on what type of numbers are available, and probably presenting as a group of the non-fentanyl synthetic opioids might be the category, just to have enough numbers at some point. But I think that would be my thinking around that question. But Reagan, your office is providing the data for the tool, so I'd also want to hear from you.
Yeah, we'll definitely continue to monitor, and as we have more, unfortunately, we'll likely identify more cases and consider the best way to integrate and as well provide in a timely way as possible. And I hear that from the audience that need is there, and so we will continue to try to really think about how we can integrate that into reporting in either the interactive tool or other mechanisms.
Thanks, Reagan. Thanks, Jennifer, for sharing the alternative model to drug criminalization in Toronto as a resource for others. There's some other questions in the chat. Natalie, back to you.
sorry, the chat just moved up for me. Are fentanyl and derivatives therefore appearing in illegal marijuana? Nick, did
I
you
take that one? This is the bane of my existence, this question. For years, we've been getting this question. I don't know, I'm not sure why it continues to pop up, but there is absolutely no evidence of fentanyl or other opioids in cannabis. It makes absolutely no sense pharmacologically or even from a price point that it would be in there. I'm going to put a link in the chat right now to a document we put together around this a while back. It still holds true. There's never been any lab confirmed analysis to find fentanyl in cannabis. The only possible way I can see something happening is if someone might have been using a surface or scales to weigh out fentanyl powder, and then they also put their cannabis down to maybe roll a joint, and there's accidental cross-contamination, but I'm not aware of that. So I please encourage you to read the link I put in the chat there. We need to stop this myth that fentanyl is in cannabis because it's doing more harm than good.
There's a second part to the question that asks about whether we're seeing some of these NSOs in other products geared to other audiences like stimulants and other drugs. And I think that the product that Nick is talking about that Oren has available, the resource, would answer that. But it would then again fall under cross-contamination. As somebody who uses drugs, our dealers aren't trying to get us hooked on opiates if we're trying to buy stimulants, because it would produce the opposite effect, and if essentially you would lose clientele, one, to death, and two, because you wouldn't be selling them the products that they're looking for, potentially cross-contamination. But as a person who uses drugs, and I can see Ashley nodding, I think that this is something that may happen from, a scale not being wiped down, but not intentionally. The next question.
Sorry, and Natalie, this is because someone's commenting in the chat there, Austin from OHAS, that's the Ontario Aboriginal HIV/AIDS Strategy. Hi, Austin. Yeah, for sure, we know that there are people that might mix their own drugs together in whatever combinations they choose to do, but from a supply and dealer perspective, it's not happening unless it's accidental or cross-contamination. And specifically with cannabis and fentanyl, there's never been a lab confirmed case of that happening.
I will add that we sometimes see people that, find a pipe that's been left behind that has residue, and they think that potentially it's residue from crack, and will like push a Burlo through and unfortunately overdose because of that reaction. But I think that most people that's like a one-off that occurs. It's not regular practice, though Toronto did see an increase with crack overdoses once in a while. And again, I think that was a cross-contamination issue that occurred. The next question was about death certificates. I just have to find it. I think it was, how are overdoses being captured in death certificates?
I can take that. I'll try to just be brief based on time, but I think the death certificates are often written with as much specificity as possible. So it could indicate, acute fentanyl toxicity or acute fentanyl and methamphetamine toxicity. So, from time to time, we'll see, a synergistic effect of multiple substances if it can't be delineated, but often it tries to be as specific as possible so that there would be articulation of all the substances that felt the coroner or forensic pathologist identified as being related to the toxicity event.
Great. Reagan, this one might be for you as well. We keep picking on you. Are those receiving OAT dying of overdoses and the illicit drugs identified as the cause of death, or are all the drugs found in the person reported as causative? So I'll ask you that one, Reagan, and then if others are interested to contribute.
Yeah, so I would, so make sure I just kind of two questions here. Are those receiving OAT dying of overdoses? So I think the answer is yes, there are some individuals who would be on OAT who would be dying of an overdose, either related to specifically their OAT medication or exposure, or in combination with other substances. So for example, it could be a methadone and fentanyl toxicity, or methadone and an alcohol combination, for example. So we would definitely see, and I would say generally both the methadone and the fentanyl would be listed in the cause of death statement.
Thanks, Reagan. Did anyone else want to comment on that question? I'm not sure if, I guess just from a perspective among people who use drugs, if there's anything else, I guess, just from the community experience.
Sorry, I didn't necessarily catch everything Reagan said there. I was typing in the chat, but the only other thing to consider with people on OAT is just often around tolerance. Right? Often people go into treatment programs, their tolerance comes down a bit, and then they come out and they're much higher risk for overdose.
Yeah, and I'm happy to, if you'd like to connect with me directly, if you have questions, I can assist with.
I don't see any other questions in the chat. Pam?
I don't either. So I think actually, because we're up to our last 2 minutes, and I know Natalie, we wanted to ask for you to lead us in a moment of silence as we're closing. I wanted to thank everybody for their active participation today. It was a really informative discussion. I think an important discussion of where we're at in the overdose crisis, and I'll turn it over to Natalie. We'll follow up after the webinar with the evaluation survey and the resource document with the recording, and then the slides to be posted later. So over to you, Natalie.
Thank you very much, Pam. I'm going to keep my camera off because this week was very hard. And so doing a moment of silence, I'm just also reminded of the 5 people that we lost in our community in Peel this week. So we want to take a moment to remember all those we've lost to failed drug policy and a poisoned illicit supply. We also want to thank people who use drugs and have been on the front line of the war on drugs, that are often also the victims of overdoses themselves, and grieving the losses of friends, family, and their community members. The time for talk is over. We must begin to see action from our government, or we simply will never see an end to the mass losses Canadians are experiencing. COVID-19 has shown us that the governments can align and respond quickly to a public health crisis, yet our crisis has remained in the background, stealing the lives of the people we love. We ask you to take a moment now and consider your place in the response, and remember all those we've lost while we await our government to respond. Thank you.
Thanks so much, everyone. Have a good rest of the day. Thanks to everyone for your presentations, panel contribution, questions, and Trudy, Caroline, Lydia, Monica, Amanda for all the help with the logistics and planning. Thanks, everyone. Have a good day.
Thank you.